So, we're going to do an abbreviated show today, but on a topic that is so important, especially now with COVID-19 still omnipresent across the country. In many parts of the nation, it is spreading, and we are seeing hospitals that are getting ready to maybe go out of business or change their business models over to some bigger company. We've got smaller primary care physicians who are thinking about abandoning their practices because it is just too expensive with all the regulations that they've been faced with. And now with COVID-19 and the shutdowns where they were basically told you can't have your patients come in for most situations. I mean, so many issues that have just been plaguing primary care physicians across the country. And today I want to delve into that exact issue with Dr. Lee Gross, MD. He is president of Docs for Patient Care Foundation and the owner of Epiphany Health. And he joins us now to dive into several different related topics here, particularly about putting patients back in the center of providing medical care. Dr. Gross, welcome to Jimmy at the Crossroads. It's such a pleasure to have you here.
Thank you so much, Jimmy. I really appreciate having the opportunity to talk with you.
You are in Florida. You are a physician in Florida, and I want to know what the environment really is like on the ground there for you guys, especially in terms of the spread, but also the hospitalizations and the death count, because those are, I think, what really matter more than the spread. A lot of people can get the virus, but if the communities are handling it well, that's an important thing that people should know about. So what are you seeing on the ground in Florida right now, Doctor?
Yeah, so as you mentioned, Florida is the world's epicenter now of the COVID-19 crisis. We talk about Italy, we talk about Spain. It's Florida. This is where it's at. And you mentioned we actually have a healthcare crisis right now where it's so bad that we're actually putting our physicians out of business with the policies that we put in place. We are at a point right now where we've canceled elective surgeries, canceled elective procedures to preserve the capacity of the hospitals. And what's happening is the hospitals are largely sitting empty as a result of it. So we're furloughing nurses, we're furloughing staff, we're cutting physician and staff pay because the hospitals are largely sitting empty as a result of the decisions that have made. But we are definitely seeing the numbers in the hospitalizations starting to rise, but nowhere near at the pace of which the number of cases are rising. When COVID-19 first came here to Florida, we were seeing an admission rate into the hospital of about 30% of all cases that were diagnosed. That number's down to about 3% now. And so that is a very manageable figure at 3%. What's not manageable is 3% of 15,000 new cases per day because these patients stay in the hospital for a while. So we do have to slow the spread, but this is concentrated really in about 6 different counties and 6 different population hubs around Florida. So your main areas where the populations congregate, and then in the other 61 counties in the state of Florida, there really is not a whole lot of disease present. And that's just something that's not really talked about. It's mostly in the nursing homes, it's mostly in the prison population, but we're just not seeing, in the general rural communities, massive crowding and hospitalization.
Define for a moment, please, what elective means, because a lot of people, when they hear elective surgeries, unless they had an elective surgery canceled on them, they might think of something that's sort of frivolous, that isn't necessary or isn't something that is important to somebody's health and well-being. Might be just, plastic surgery, for example, that isn't a necessary thing. You might think, oh, that's elective, but that's not the case, is it?
It's anything that's non-life-threatening. So elective can be a bypass surgery. If you're not dying of a heart attack right now, then elective surgery can be your gallbladder. It can be removing cancer. Cancer is not necessarily an emergently life-threatening condition, but as you're delaying these services, as people are avoiding the physician, we have a point right now where people are afraid to go to the doctor. And that's the morbidity and mortality associated with people being afraid to go to their doctor is going to be one of the major fallouts of this entire COVID conversation, which is actually one of the important reasons I'm glad we're able to talk about the practice model, because it's something that we have actually been able to audible very quickly and be able to provide care for our patients where other practices were not quite so fortunate. You had alluded to, 50% of primary care doctors right now in a fee-for-service world are near bankruptcy. They're near insolvency. And we're going to see more consolidation in the medical practices. We're going to see more uptake by hospitals buying out these vulnerable practices, and you're also going to see this hit particularly hard in the rural communities as these rural hospitals that were already bordering on insolvency are going to go broke, and that's just not something that we can sustain.
Just one final question, and then we'll jump right into the model with you, Dr. Lee Gross. In terms of ICUs and manageability, I mean, ICU capacity is broader now than it was when the COVID-19 crisis began. So in terms of the ability to manage this, first of all, I think it's pretty remarkable that we've gone from 30% of all cases to only 3% in Florida as far as those who actually need hospitalization. That I think there's a lot there in and of itself. But in terms of that larger 3% number, when you actually say 3% of 15,000 cases a day and what have you, certainly that is a very big issue for hospitals to be grappling with. So in terms of managing it, though, especially with the enhanced ICU capacity, how do you view that as being done right now? How are they handling it in terms of managing these situations in the hospitals?
Yeah, so in the first 5 months of this pandemic, the hospitals have worked on surge capacity. So we were expecting this. Nobody ever said in the COVID response that we have to flatten the curve because we're going to cure COVID by doing that. What we said is we're just going to extend out the number of time it takes for the same number of people to get infected. But the numbers under the curve is not going to change. It's just going to slow. Having said that, we have a wildfire right now in Florida, and we want a slow burn. We want a controlled burn. And so we do have to make smart decisions as a society as to how we're going to get that under control so we don't overburden any particular health system. But when you see that the intensive care units are near full, that is just a licensed bed capacity, but that is not a hospital's ability to take care of patients. They have developed overflow plans, they've developed staffing capacity plans and surge plans to take care of these people. My concern really continues to not be the intensive care unit beds, but the ability to staff those beds. And that's also why it's very important for the federal government to have an idea of what's going on. I'm sure you've heard the kerfuffle over bypassing the CDC so that HHS can start collecting information directly. That was the ability for the federal government to audible, to be able to allocate medications appropriately, to allocate resources appropriately. And unless you have real-time data as to what's happening in those hospitals, you can't get out in front of this. So that was all part of that whole process.
So, Dr. Lee Gross, let's talk for a moment about the current model, how it's set up, and particularly how COVID-19 fits into that.
So a standard practice is an insurance-based practice, which basically bills on requiring a patient to have a face-to-face presence with a physician in the office. So the way that works in the standard times is every single phone call, every single email must convert into an in-person office visit in order for the doctor to bill the insurance. And typically that office visit's about 5 minutes long, and of those 5 minutes, 4 of them are with the doctor clicking boxes in the computer so they can bill the insurance and get paid properly. Lord forbid if you actually have 2 problems, then you need to get in line and come back again. But the Medicare and insurance companies generally did not value technology visits. They did not value a communication like you and I are having, a video chat. That is not something, telemedicine, that's not something that's billable under our typical insurance. So what happened when we hit COVID, so what we have is what's called a direct primary care practice. We are an insurance-free practice, and the name of our practice, Epiphany Health. The epiphany, in fact, was, why are we insuring primary care? Why are we inserting an insurance company into the most basic aspect of healthcare delivery? And it's a very impersonal product, this insurance product, and yet we're surprised that it's inefficient, ineffective, and impersonal. You don't insure your car, you don't insure gasoline for your car, you don't insure lawn maintenance in your house, yet we're insuring every single aspect, every sniffle, every cough. So what we did was we created more of a Netflix approach to primary care. We charge a flat monthly fee to our patients for unlimited services in our office. So for us, that's $65 for an adult, $25 for one child, and $10 a month for each additional child. And after that, we don't charge anything for services we do in our office. Office visits, technology visits, email visits, skin cancer surgeries, joint injections, EKGs, any in-office testing is all included at a flat monthly fee. So we are charging for why would I charge you $50 for an EKG when it costs me 3 cents to do it? We've eliminated barriers and obstacles to care. And what effectively happened in this pandemic is it's really stressed the weaknesses of the fee-for-service model in primary care. Because when you started cutting off primary care doctors from seeing their patients in person, you've suddenly cut off their revenue. They have no way of billing. And if it takes Medicare or Blue Cross 6 weeks to change their payment policies, that's 6 weeks of no patient care, no revenue, and these practices go broke. We didn't have to do that. We immediately switched to parking lot visits, technology visits, drive-up nasal swabs, you name it, whatever we had to do, wherever we had to do it.
And that's because
we never had to lay anybody off.
Because you're interfacing directly with the patient and not working through all of these systems necessarily.
We did not need to ask for permission to take care of our patients, and we didn't need to ask permission and wait for a federal mandate. We didn't need to ask for a board meeting from an insurance company to give permission for us to do the right thing for our patients to take care. It happened on day number one. And because we had the steady revenue stream of the memberships, we didn't lose the revenue. We were concerned that a lot of patients were going to drop their memberships when they lost their jobs, but it turns out that never happened. Because I guess it turns out that in a pandemic, the last thing you want to do is drop your relationship with your doctor.
Yeah, it's funny how that is. When you have a pandemic and a virus is spreading, you actually want to keep your primary care doctor handy so that you can communicate.